Good morning. Hello, I'm Dr. John Kruse, and welcome to today's question and answer on ADHD and Mental Health Hour. So, as is the custom, I will give a 1 minute summary on each of the three videos that I released last week. One is new, the other two were sound re recorded by Max, or sound adjusted and fixed. And one other announcement is that the timing, so next week will be an hour later, and I think that will be a stable time going forward on Tuesdays. So it will be 8 o'clock Hawaii, 10 o'clock West Coast, 1 p.m. East Coast US, and things I can't even calculate in my head right now for Europe and the rest of the world. So first of the three videos, the one new one that I released was about combining medications for ADHD. So the summary is that depending on what study you look at, anywhere from 5% to more than half the individuals who are getting medications for ADHD are on more than one medication. The combinations that have been studied most extensively are combining guanfacine with a stimulant or combining Strattera with a stimulant. And I'm sort of ignoring the topic of combining short-acting and long-acting stimulants. That also has been studied. In combining medications from different classes, the studies so far have shown that it should be safe. We're not introducing new side effects or complications with almost any of the combinations available. And at least in a few cases, there is demonstrable improvement in further symptom decrease by combining multiple agents. So I'll just leave it at that. The second, which was a re-release, was using guanfacine for ADHD. So guanfacine in the form of Intuniv, which is a long-acting form of guanfacine, was approved for treating ADHD in children a few years ago. Guanfacine is an alpha-2A noradrenergic agonist. So it's not working by directly blocking reuptake or making more norepinephrine immediately available, as many of the stimulants and things like Strattera have major actions in that way. So this is modulating. It's a receptor that's most often on neurons that are receiving glutamate in the prefrontal cortex, at least. And the evidence suggests that it is instrumental in causing increased new synaptic connections between neurons and probably strengthening executive function capabilities in the prefrontal cortex. And those are mechanisms that take a while to develop. So it really is. Many of the sources indicate that all of the non-stimulants take a long time to work. I'd say anything that's making dopamine or norepinephrine immediately available, like bupropion, like Strattera, should work quickly, at least some of its effects. Guanfacine tends to work slowly. There are some individuals who observe faster reactions, and it's particularly useful for combining with stimulants for people who feel too revved up with stimulants. It does lower blood pressure, or can, so that can also help prevent some of the cardiac side effects of stimulants. And then the third topic or video that was re-released this week was amphetamines or amphetamine induced psychosis. And I have been just shocked by, I've had patients when I was working in San Francisco, moved to the city, who had been treated at every major ADHD clinic around the country. Lots of people like moving to San Francisco in those days. And every time I brought up the topic of amphetamine-induced psychosis to a person, they said, nobody ever told me about this risk. So the risk is about 1 out of 600 people on prescription amphetamine-based products develop a psychotic syndrome. The scary things and prominent feature is paranoid delusions. Often people are more energetic, sleeping less. So there are some aspects that resemble mania, but there tends, at least in all of the cases I've seen, none of them were bouncing around from positive mood states to they were pervasively paranoid. Um, anyway, the scary things about this is that classically it lasts for days, weeks, or months after the drug has left someone's system. So it's saying we have changed some people's brains for the worse. And a small amount of data we have suggests if you look 15, 20 years out, about 20% of these people are in a permanent schizophrenic-like state. So this is a very serious side effect. It's not particularly common, but 1 out of 600 isn't that rare. The risk for methylphenidate products seems to be negligible, at least in a few studies. So it's the background rate. So those are the 3 videos released. And again, I'm open to um, questions on those topics and other topics. I did have at least one. There was one comment or question from Bees Mongeese, Mongeeses, asking me to explain my, I guess, sort of summary of Strattera. So my summary of Strattera or atomoxetine is, if it works for you, great. It clearly works in a number of studies for people with ADHD. On the other hand, and I think the feedback and comments to my video are consistent with what I said, very many people who start out on it have so many side effects that are so unpleasant that they can't stick with it or don't want to stick with it and don't stick with it long enough to get up to an effective dose where they see results. I believe that if you were able to start at an effective dose, you would see benefits immediately, but most people, again, take weeks to titrate upwards to that dose. So I almost never start individuals on Strattera, and in the small group of ADHD specializing psychiatrists in San Francisco, except for one child psychiatrist, very few of the others would rely on Strattera as a starting option for people who didn't want to start with a stimulant. And the go-tos that were more commonly used are either bupropion or duloxetine. Again, duloxetine is a dual serotonin and norepinephrine reuptake inhibitor. Its impact on norepinephrine reuptake is as robust as Strattera. And you might think that hitting 2 different neurotransmitters would give you twice as many side effects. But again, these are systems that are modulating each other. So often hitting 2 together may result in fewer problems or side effects. So I see some questions have come in. There's a question from Javier, but all I'm seeing is a comment that says, my nephew is 7 years old. So I'm looking for more. I'm not seeing more to that one. So, hello, Dennis. Dennis asks or says, his psychiatrist said that cannabis sensitizes the nucleus accumbens. Are there healthier ways, pharmaceutical or natural, of sensitizing the nucleus accumbens that don't involve smoking cannabis? I mean, simplistic rather than smoking would probably be gummies. I am not that familiar with the evidence. I'm not even quite sure what someone says or means when they're saying sensitizes. My guess is a study found an association between activity and the nucleus accumbens. So the nucleus accumbens is at the base of the brain, it's small structure where the majority of cell bodies of cells that use norepinephrine as a neurotransmitter in the brain are located. It sends projections to prefrontal cortex and other regions in the brain. So I just am wary of going beyond the claims of what looking at associations or correlations and saying that we know for sure what's a mechanism of action. And I'm not even sure how we would define being sensitized. And some would say that people with PTSD have an overly sensitized nucleus accumbens. So just sensitizing it wouldn't be necessarily desirable in all cases. One option other than smoking cannabis certainly would be gummies. And when we're talking about cannabis, I'd say there's pretty compelling evidence that, jumping back to the rare risk of psychosis, is associated strongly with THC. CBD seems to actually have some protective effects. So CBD-based options may be a safer choice. So Goosebumps 000 says, hello from Sweden. Hi. Thanks for the videos. Is there a safe way to use cannabis while having ADHD medication? So I do have a talk just on marijuana and ADHD. It is the one topic that I can think of that reading what's been published research wise changed my mind or opened my mind somewhat about it. So on the surface, there's a lot of evidence for marijuana, and this is generalization, but for people smoking every day, there's decreased energy, decreased organization of thought, decreased motivation, decreased attention, all of which you'd think are a really bad fit for ADHD. But there are at least some subset of individuals, and there are some studies that back this up, that some people with ADHD do benefit from cannabis. Um, Again, smoking any substance, as long as we're not designed to be smoking cigarettes or reefers or wildfire smoke. None of those things are good for our lungs, and it extends beyond the lungs, the damage that can be done. The issue with edibles is that they tend to enter the body more slowly. So people who are sometimes can overdose taking more before they're seeing the full effect of what they're going to get. And at least in the United States, I can't speak for Sweden or other countries, when independent labs have gone in, and it's particularly Colorado is one of the states that have been tested because it was close to the forefront of allowing legalizing cannabis and regulating it. But a substantial proportion, I think it was close to half the samples that they examined, there was not much of a correlation between what the label said it contained and what it actually contained in terms of CBD and THC content. So my message there is, if you find a brand or manufacturer you feel comfortable with, stick with that one, because someone else's 2 milligrams of CBD may be wildly different from that brand's. And again, I would use it cautiously and be aware and try to monitor what you're seeing and be aware that cannabis, CBD, and all the cannabinoids are highly fat soluble, which means they tend to stick around in brain tissue a lot longer than many of our other um, drugs or medications. So the effects could be more persistent than you might be expecting. So, hi, Max, Lena. Um, was there any research on combining stimulants with beta blockers? Does using a beta blocker long term have any negative effects? So, beta blockers are initially hypertensive medicines. So they reduce blood pressure. There's helpful for some people with arrhythmias or certain heart rhythm problems. They've been used for social anxiety, particularly performance anxiety, and never FDA approved for that, but plenty of evidence for that. Some people use them more broadly for a broader range of anxiety. I did not come across, just searching combination medications and combination medications ADHD, any specific research looking at beta blockers and stimulants. So I'll just leave it at that. And in terms of long term negative effects, I'm not aware of any. And again, given that there's a large population of people, these have been antihypertensive blood pressure lowering drugs for decades and decades, with many people on them for decades. I don't know of any evidence of long term side effects that aren't there in terms of short term side effects. So Mr. AKA said, do you see a net increase or net decrease in blood pressure in patients on guanfacine stimulant combo? Do you know how likely the risk of serotonin syndrome is for those on sertraline taking LSD psychedelics? Um, so the blood pressure, some of the studies, so guanfacine and stimulants are one of the combinations that has been studied. Um, Clearly, the relative doses between the two is going to determine to some extent, and your individual sensitivity, what blood pressure, um, what the net effect on blood pressure is. Clearly, the likelihood of hypertension is decreased by adding guanfacine to a stimulant combination, but again, individual results may vary. Um, and overall, the average increase is fairly small with stimulants, but um, I've, so again, this is one area that the guanfacine may be particularly helpful if you already have pre-existing hypertension and are worried about it worsening with the stimulant. Your guanfacine may help reduce that risk. I've also had some individuals who are on other blood pressure medications who switched to guanfacine specifically to see if they could get more benefit for the ADHD symptoms through it. So, I mean, yes, it makes sense to attempt to use this to lower it. Many of our blood pressure medications are lowering aberrantly high blood pressure. So it's not that people universally drop their blood pressure with all of our agents. So low blood pressure is less of a risk simply being on guanfacine. It's not that it can't happen. And the other thing to be aware of with blood pressure is that theoretically, abruptly stopping guanfacine, some people may have blood pressure shoot up really high and withdrawal overcompensation. That's not particularly rare with clonidine, a very closely related drug, but clonidine goes on and off the alpha 2A receptor much more quickly than guanfacine does. And a few studies specifically searching for problems with withdrawal hypertension with guanfacine indicate it's pretty uncommon risk there. Um, so the other question was, do I know how likely the risk of serotonin syndrome is for those on an SSRI taking LSD or psychedelics? So the SSRIs are having pervasive effects throughout serotonin networks by being reuptake inhibitors, blocking it and increasing the amount of serotonin sitting, not increasing the amount, increasing the duration, increasing the effective activity of serotonin at the postsynaptic receptor. The common mode of action of many of the psychedelics is on the 2A subtype of serotonin receptors. I've seen some people claiming that the combination of the two, because of their differential actions on serotonin receptor systems, may actually decrease the risk of serotonin syndrome. I've seen others argue that it may increase the risk. I'm not aware of any epidemiologic surveys or studies looking at how common it is. And of people in the, I'd still say, sort of alternative health field who recommend psilocybin or LSD or other hallucinogenic trips for treating mental health conditions, some of them insist on people stopping an SSRI before they use these alternatives. Others say, don't change anything, keep doing what you're doing. And again, in terms of beneficial effects, I've heard people claim that the SSRIs can enhance it, and I've heard claims that they can block it. And I do not think we have any systematic, good research on that right now. So Goosebumps asks, do you recommend drug holidays for adults, and how long should one pause the medication? So I do have a video on some of that. So the one side effect that's been clearly shown to be less problematic in people who take, and this is in children. So children have delayed, have impairments in their height if they are constantly taking stimulants throughout childhood, but long holidays, and long means several months during the summer or maybe winter breaks, but not not taking it on the weekend. Longer breaks do seem allow normal growth to occur. And again, the growth effect is not huge. It's about 2 centimeters less than your projected height. It's not insignificant for some people, but it's not a huge effect. There's lots of claims that drug holidays will decrease the likelihood of tolerance, will decrease the likelihood of addiction, will have other, may decrease the risk for blood pressure or cardiovascular problems. And I'm not aware of any rigorous data supporting most of those conclusions. Um, so I'd say if it makes the argument against taking holidays is that ADHD is a condition that not just affects school or job performance and not just cognitive actions, but it affects social interactions. It affects all the rest of your life. So if it's helping you to be your best you, why wouldn't you want to be your best you on your weekends when you're having fun and you're spending time with the people you like to spend time with? So I mean, if you're functioning fine on days without it or well enough, I'd say great. I think always, less medication is better in some ways, but the research is really meager on whether not taking it on weekends, not taking it for a week or a month detox is beneficial in any way. So Nathan Swoop asks, "What's my thoughts on gabapentin for anxiety?" So, I mean, one is my thoughts are the probably the best approaches for anxiety are CBT based approaches, and I have a talk on thinking about anxiety as an attention problem. That so often it's that the anxiety gets fixated on some future event, and that event winding up being a catastrophic result. So it's not anxiety by definition is not a fear response. So fear is a danger that's right here and imminent and going on. Anxiety is one coming up. I mean, there are valid reasons to be concerned about future events, but anxiety by definition is a pathologic condition where you're excessively worried. So again, I'm not saying ignore the future, don't plan, don't reduce things. For medications, the benzodiazepines work for almost everyone if you take enough of them, but people develop tolerance quickly. They have lots of adverse potential effects. Um, so if the choice is gabapentin or an benzodiazepine, probably gabapentin tends to be safer. What I've been in this field long enough, I can remember that the company that made gabapentin, Neurontin, was the first company hit by the FDA, at least in the mental health field, maybe overall, where the company was sued by the FDA for pushing it for off-label uses. So gabapentin was an anti-seizure medication. They were pushing it for bipolar disorder. They were pushing it for PTSD. They were pushing it for anxiety. The drug reps were actually telling doctors it could be useful for there. And they got slammed with a multi-million dollar lawsuit, had to pull back what they were saying about it. And then a few studies came out looking at it in bipolar, looking at it in anxiety disorders, which didn't find a difference between the placebo group and the gabapentin. That does not mean that those are not necessarily definitive. One, it's hard to, I mean, all of our studies in psychiatry are impaired by poor means of measuring success. So our scales are not, lots of very bright people spent lots of time on this. I'm not degrading them or devaluing them as stupid or worthless, but they clearly fail to capture often what is going on with individuals. Um, so if it's works, so when it works, it tends to be working quickly, um, like a benzodiazepine, and unlike an SSRI. So the other SSRIs, if someone has an ongoing anxiety disorder, I would certainly focus on that rather than on gabapentin or a benzodiazepine. The other thing with gabapentin, there's such an incredibly broad range of effective doses. So daily doses are anywhere from 100 to 3,600. So if you're not seeing much, the question is how high do you keep going? Usually sedation is the limiting factor. Again, these tend to be not quite as clear cut sedating as benzodiazepines, but they can be sedating and impairing if they go too high. So if it's working for you, great, but it's not one I jump too quickly. Chris Nyquist said, if I had a paradoxical effect from guanfacine at age 12, would it still be that way 45 years later? So brains are still clearly developing and changing at age 12. And so, and you don't, without knowing what the effect was or how bad or unpleasant it was, to me, if you are still, for example, having ADHD symptoms at age 57 and haven't had good results with other options, I would not rule out trying guanfacine again, um, at least from what I'm hearing. And again, I cannot make medical recommendations. I'm here to provide general information. I don't have a complete history. I'm not evaluating you in the moment, but theoretically, it does not strike me as unreasonable, even if someone had a unusual or paradoxical or even a mildly bad reaction to a drug at age 12 to retry it 45 years later. So Gutek 252 asks, do I know if taking Lamotrigine can worsen eczema, atopic dermatitis? So, and so atopic dermatitis is thought to largely involve autoimmune processes. I don't know specifically of Lamotrigine. I don't know if there's studies about it worsening it. I know with Lamotrigine, it's an anti-seizure drug, which has been also FDA approved for bipolar disorders, particularly helpful for the depressive state of bipolar disorder. And compared to drugs like lithium and Depakote and antipsychotic mood stabilizers, has very low to no risk of weight gain, tends not to be sedating, so tends to be very low in side effect profile, with the exception of rashes. Particularly if you titrate up too quickly, lamotrigine can cause fatal rashes. That's extremely rare. But the commonest side effect with lamotrigine is benign rashes. So 10 to 15% of people have some sort of rash. So at that level, maybe given that lamotrigine can promote a multitude of types of rashes, it could worsen eczema, but I'm speaking more from my clinical practice and reasoning rather than data there. So I'll stop. So Rec, Rexep RS says hi and 30, and sorry again for butchering names. Used Ritalin and Concerta 2 years ago, but it worsened his ADHD symptoms. Why and what should I do? So one concept I bring up is that unless you have a very, and this always sounds a little derogatory, and I don't know how to say it in a way that doesn't sound derogatory, but one of the things that's measurably true is that people with ADHD, because they're inattentive, are not always expert at assessing their own ADHD symptoms. And the example, I'll just, the made up example I have is, say 20 times a day you go into the next room and you forgot what you were going to do, but you're not paying attention. So in your unmedicated state, you're saying, that's happening a lot. That's happening 7 or 8 times a day. You take a medicine that helps, and it helps so much it cuts it in half. You go down from 20 to 10 times a day. But now, because you're paying more attention with the medication, you're aware it's happening 10 times a day. In your head, you've gone from 7 to 10, things have gotten worse. In reality, you went from 20 to 10, things got considerably better. So, one thing to be careful about is, did symptoms really get worse, or were you just more adept at paying attention to the symptoms that were going on? Um, if if it's genuine symptoms got worse, one common possibility is we have what's called a U-shaped curve for alertness. So if a little bit of stimulation helps all of us be more alert, if we're too overstimulated, we get too scattered, too distracted, can't focus on what we want to focus. So it could be that the dosage of the medication was too high and pushing you from an um, understimulated state to an overstimulated state. Um, so without knowing more of the details, I mean, it may be possible to try those same medications back at a lower dose and with rating scales. So this is one of the few places I think rating scales are can be quite helpful to assess symptoms. I mean, it may be worth trying something like guanfacine that's working on a completely different system, or maybe modafinil that's may or may not be working in a different way. So Flynn asks a good question, and I do have a talk on caffeine. Would there be any reason to combine caffeine and stimulants, or is it always better to just increase stimulant dosage to replace it? So that's one area the ADHD experts, when they talk about this, are sort of evenly divided. So they all acknowledge caffeine is a stimulant. You should be paying attention to it, particularly if you don't have a fixed dose every day. Be aware that if you're taking it today and not other days, or a bigger dose today, that you may see more of an effect. My summary is that on a dosage per dosage basis, and usually we're using caffeine at much lower effective doses than stimulants, but it's actually a fairly lousy stimulant. So there's more tremor, there's more agitation, there's more cardiac side effects at a comparable effective dose. But some people like caffeine. Some people have their tea or coffee ritual. Some people that has psychological or social benefits beyond just a caffeine dose. So, so some of the experts say it's a bad stimulant, get rid of it, just use what we can measure precisely in terms of prescription medications. Others say, you know, it may help you get by with a lower dose of a prescription stimulant, just monitor it. And if you're changing your caffeine, coffee, or tea intake abruptly or substantially, be aware that may have an impact. Um, so my approach is to share information and see what works for the individual. And my own bias there is I think I was only one out of 116 people in my medical school class who was not a coffee drinker going into medical school and was not a coffee drinker by the end. So I've only had 3 cups of coffee in my entire life. So maybe I certainly don't have much experiential evidence to add to that such conversation. So Max Doppler asks, was I diagnosed with ADHD? And no, I've never been diagnosed with ADHD. And I would say for most of my life, I think I've been at the opposite extreme of being extremely organized, extremely adept at directing my focus where I wanted it to be. Not being hyperactive. I know I do bounce my feet when I'm talking here, but I don't know that I did that most of my life. So whether it's immersion in the internet in the last few years or aging or other processes, more of these ADHD symptoms resonate, or just simply aging resonate to some extent. But I don't think I'm on the ADHD spectrum. I've had some family members, but not strongly or pervasively throughout the family, who also I think are on the ADHD spectrum. Um, so Sliman Bisharat said, any new medication, ADHD with comorbid anxiety. Stimulants have a rebound effect, and SSRI, SNRI don't work. Non-stimulants don't work for me also. I mean, one question is whether Qelbree might help. So I do have a talk on that. Um, Initially, it was thought to be a norepinephrine reuptake inhibitor. It's probably having much more complex effects on subsets of the serotonin system. So it's not a simple SSRI or SNRI. So there are certainly some individuals who feel it helps not only with their ADHD, but also with anxiety. You mentioned non-stimulants, but I'm not sure whether guanfacine is something that you've tried. So guanfacine, some people do take for anxiety, and again, it is measurably FDA approved effective for ADHD. It does tend to work slowly. So those are the places I would start. I mean, I do have a talk on buspirone. It's considered a second or third or fourth tier ADHD medication, but good for anxiety. It works slowly for that. Um, Fish oil, omega 3s may be something to consider, with some evidence for mood and anxiety and some evidence for benefit with ADHD. So Mr. AKA is getting back to the Gabapentin conversation and saying some of the off-label promotion of these drugs is wild. Um, and he's recalling that some company was pushing fentanyl lollipops for migraines. Yeah, I'm not supporting that practice. I would just say, and I have not myself had migraines, but they can be incredibly incapacitating. And for many migraine sufferers, none of the available drugs, even though there have been remarkable advances in treating migraine recently, have helped. So I get that we don't want to be handing out lollipops for everyone with a headache, but I wouldn't. But I also want to push back against I think the overly discriminatory view that anyone who takes an opioid is really taking it to get high. I mean, it's similar to what some people think about stimulants, that these are not real drugs. These are drugs of abuse or drugs of enjoyment, and that there aren't real legitimate medical needs for them. So Josh asks, can low doses of methylphenidate cause depression, symptoms, fatigue, but high doses do the opposite? I took 5 ants, which was great, but I was still having sleep issues after 2 months. So I usually start by saying anything is possible for anyone's reaction to medications. I'd say usually low doses of the dose of methylphenidate or and the active ingredient of Vyvanse is a dextroamphetamine. But low doses of stimulants usually aren't causing any effect or milder effects. I haven't seen them producing depression, but anything is possible. I guess if they helped you slow down or focus your thoughts, you could become more in tune with negative ruminations causing fatigue. Um, I've had people become more aware of the normal circadian siesta time lull in activity in midday once they were on medications, but whether that's actually causing or adding to that midday lull or making people more aware of it, I don't know. So I'm not sure I have too much helpful there. So Max is saying, but gabapentin and pregabalin are primarily painkillers, right? Is using them as an anxiety drug off label? I think they may have unpleasant side effects, especially when taken too excessively. So again, they gabapentin Neurontin initially was a seizure medication, and for years that was its only FDA indication. Pregabalin or Lyrica has been approved, and there's a for chronic neuropathy. So it's not an analgesic. So medications that directly immediately relieve pain are analgesics. Other medications that probably work on how well pain signals are getting into the brain or processed in the brain and are helpful for chronic pain. So if you stub your toe, Lyrica is not going to be much of help. But there are people with HIV neuropathy, diabetic neuropathy, other chronic pain conditions who are helped by these drugs. Um, so, to my knowledge, neither of them are approved in the US or other countries for anxiety. So, yes, that would be an off label use. But again, a reminder is a good number of our ADHD medications were only, or at least initially, approved in kids, and it took decades before official approval in adults. So those were then off-label uses until they were officially approved. So I wouldn't worry too much about whether something's off-label or on-label. I'd focus more on, do we have real evidence that it works, rather than so the approval process in the US isn't just the FDA approving something or not. It's whether a pharmaceutical company wants to spend, and it's tens of millions of dollars to do the studies to seek the approval. And if the drug can already be used, again, they may not be able to advertise it for that function, but um, a drug can still be used off label. So Mr. AKI asks, what do I think about giving anxiety patients benzos? And if they have to escalate dosage too much over time, then you temporarily put them on a GABA antagonist like uh, flumazenil to upregulate GABA receptors. So my thought there, I mean, it's not a practice I engage in. My thought is, if someone's escalating and their system's upregulated, rather than trying to keep messing with the system that we've pushed too far in one direction, I would again try to be tapering them off. And benzos, some people do need to be tapered off really, really slowly, and focusing again on other, hopefully primarily psychotherapy, behavioral approaches, and or other neurochemical systems where there seems to be less tolerance developed. So particularly the GABA system, whether it's alcohol or benzodiazepines or others, seems to be a system particularly prone to developing tolerance and health problems, um, rebounding from that. So Monir or Almardi asks, do I see a connection between romantic obsession and ADHD? So I do have a talk on obsessive compulsive disorder and ADHD, whether romantic obsession is really a true obsession, whether it's more an addiction. I'd say, and I don't know if there's rigorous data. I mean, I know there's data showing people with ADHD are more likely to not have a partner, to be divorced, to have relationship problems. I would say clinically, yes, I think there's an association, or a greater tendency to rush quickly into a relationship without knowing someone well, and that being obsessive. I mean, there's probably, again, addictive characteristics to, and I don't want to be demeaning, but calling it puppy love or first love, or, that there are reinforcing neurochemical systems at play here. But yes, I think clinically, but I don't know that we have evidence on that or rigorous studies on that. So Max is asking, is there a link between ADHD and tension headaches? How do you approach treating headaches clinically? Good question. Um, I'd say I don't know, again, the research base on that. I would be surprised if there wasn't a connection, just because tension headaches seem to be related to psychological and cognitive stress. And many people with ADHD, whether they're being forced to work their brain in ways that are they're not accustomed to, or that they are less adept at than others, are facing stress because of that. Difficulties with time management and regulating workflow would also contribute to factors that seem to be associated with tension headaches. So I'd say the workup or evaluation for headaches would start out with the description of what the headache feels like. So there are some classic, um, there's a form of cluster headaches that feels like an ice pick stabbing you. So where it is actually experienced, what part of the face, eye, head, is important when it's happening. So there are certain headaches that have strong circadian rhythm patterns. There are other headaches, that are strongly associated with a given activity or trigger. So tension headaches should be happening when you're feeling stressed out or tired. Usually felt across the back of the head, but can be felt other areas, whether it's only half the head, like a migraine classically. So a lot of the workup for headache is history taking. So finding out more when they're happening, what they feel like, are there things that make them better or worse? I mean, there are certain cases, if there's evidence to suggest there may be seizure activity involved, and an EEG may be helpful. I mean, if someone never had headaches and there's a sudden onset, I mean, there's certain things also like a stroke or a bleed that can create one massive crashing headache. Usually you'll have fairly dramatic blood pressure, other bodily physiologic changes as well that will tip someone off that this is, not just a headache, but a major crisis in the brain. Um, so brain imaging may be indicated, but it's usually not the first screening step for looking at headaches. And I guess the rest of the approach clinically is if there's some people with tension headaches where those are made worse with stimulants because stimulants are, again, feeding into the sympathetic nervous system. And for some people, that can be causing probably blood vessel contraction and or spasms that may have a role in migraines as well. So looking at our medications for the ADHD causing a link or worsening symptoms would be important to sort out. So, sure, if no medication is helping for stimulant-induced medication, then stimulants might not. So again, if you've tried a range of dosages, I mean, if you started low and made sure you weren't seeing benefits there, if you've tried both methylphenidate products and amphetamine-based products and didn't see good results, and if you've tried slow release formulations and immediate release formulations, so often people try an immediate release formulation just because it's a quicker way to see, am I going to get any effect out of it or not? But there are certainly some people who can't either tolerate or don't see much of an effect. In terms of, does Focalin cause less anxiety compared to Concerta or Vyvanse? I'd say not. Certainly, there are individuals who get a good response to one and not to others. But overall, I mean, my experience is that Concerta has been, particularly if you get the name brand or a osmotic release one, that is the long-acting methylphenidate product that I've heard the most consistent positive responses to. And for amphetamine-based products, Vyvanse, again, I mentioned it in my talk on Vyvanse, people consistently refer to it as smooth. Um, so again, a given individual may do better on Focalin than on either of those two, but I would not expect it, and I probably wouldn't even push to try that if they've gotten fairly consistently negative results on multiple. So Chris Nyquist asks about gabapentin for restless leg syndrome. So I do have a talk on restless leg syndrome. I'm not remembering whether it's actually been FDA approved. There are studies indicating it can be helpful. And again, with restless leg syndrome, some of the dopamine acting agents may actually, even though they're clearly helpful, may perpetuate or even worsen the process over time. So some experts are more in favor of using gabapentin for that use in terms of maybe less likelihood of hypersensitizing or pushing the dopamine system too far in a bad direction. Um, so I do have a patient in 10 minutes, so today I have to watch the time. I see there are a few questions coming in. Yeah, so if stimulants induced anxiety, that would be suggestive that the dosage was too high to me. And I talk about this more. I talked about it a little bit in the combination medications. There are numerous people who cannot tolerate stimulants, are just too revving up, too excitatory until they stop the stimulant, get on guanfacine. Guanfacine, for some of them, helps enough that they don't need to try anything else, or some of them, guanfacine helps somewhat or mildly with ADHD symptoms. But then they are able to go back and take a stimulant and not have the host of agitation, anxiety, tremor symptoms they had that initially prevented it. So there are people who could not tolerate stimulants who can tolerate them fairly simply with once guanfacine is on board. Is there a take it as you need it, not everyday medication you would recommend for adults with generalized anxiety disorders? The simple answer is probably not. I mean, if they have, and by that I mean generalized anxiety disorder by definition is an ongoing, long term, fairly pervasive situation or condition. And I think it's really hard to say, okay, you can take Klonopin today for this anxiety, but these other anxieties you're worrying about or things aren't a reason to take it. So for me, I mean, I have had people who came to me on such regimens. I mean, of the benzodiazepines, Ativan is the one I like most because the ones that are too short, like Xanax, are we know have the highest propensity for causing addiction because they wear off so quickly. The rebound anxiety is so high. It's very likely someone wants to take another one. The long acting agents like Klonopin and Valium are just more prone to people running into accumulation over time and getting into dosages that were too sedating or too difficult or too much without realizing it because I'm just taking one a day. Well, a lot of the Valium you took yesterday or the Klonopin is still in your body. I do have one patient taking buspirone, and I think it's a placebo effect, but it works really wonderfully for them to take it acutely for their anxiety. Um, I'd say probably of all the drugs we've talked about, I feel most comfortable about using gabapentin as a PRN on an as needed basis for anxiety. But again, if someone has an ongoing pervasive anxiety disorder, trying to find ways to tackle that more systematically than just spot treating anxiety when it's worse. Um, so I don't see any more questions coming in, which works well for me time wise. I'll be able to stand up and walk around um, before the next patient. So I will be. So next week we will be an hour later, and I'm hoping that that new time I've cleared the schedule should be a good ongoing time. I hope it works for all of you. You can certainly write in comments to any of the specific videos or my dr Dr. John Kruse at gmail.com. You can send in comments there if you don't want them to appear publicly on this forum or other. Um, s- so I'm not sure what microphone ducking is. I mean, that is the microphone right here. I probably shouldn't just have touched it. It does have a new cover on it, so hopefully that helps with some of the sound. So if guanfacine is not available, there are other alpha 2 agonists. Clonidine was actually found to be helpful for ADHD before guanfacine was. It certainly can be effective. The big risk, though, is with clonidine. It is a real phenomenon that people who miss a dose or suddenly stop it can have blood pressure that skyrockets to dangerous levels. So make sure you have a backup supply or fill it in time and have a system to remind you to make sure you're taking it every day. That doesn't mean every missed dose results in a disaster, but it can. The rebound hypertension is often substantially higher than the initial hypertension that someone was using it that was being treated for it with. Okay, so I'm not sure what the word, or what the phrase microphone ducking means. Does that just mean it's appearing as ducking below the screen, or that? I guess you'll let me know later. So stay healthy, stay happy, and I'll be back next week.